Good afternoon, and welcome to a very special virtual session titled How Telemedicine is Helping Eliminate Disparities in Treatment, Access, and Outcomes with Access TeleCare. My name is Joa Hogan with ServiceShare Education. We will take questions throughout this session. Please use the Q&A tool and type in your questions. This session will be recorded and included in the ServiceShare on-demand video library that can be found on serviceshareonline.org. I'll now turn it over to Jim Green, Vice President of ServiceShare, to get us started.
There we go. Helps when you get off mute. Good afternoon, all. I appreciate you joining us and taking some time in your day. Like Joe said, I'm Jim Green, Vice President at ServiceShare in the Iowa Hospital Association. I want to introduce you to our partner, Access TeleCare, and to Dr. Gallagher, who's going to be answering some questions from me today. Hopefully you'll find those useful. Dr. Gallagher is a board certified cardiologist and serves as Chief Executive Officer at leading Access TeleCare and leads them to be a leader in specialty telemedicine. Good afternoon, Dr. Gallagher. How are you?
Hey, Jim, I'm doing well. Thanks for hosting.
You bet. Well, I think we'll go ahead and get started unless you want to say anything off the bat, but or we can just get right into question number one.
I think it'd be great. Let's jump in.
All right. Thank you. Thanks for doing this today. Question number one, the Health Resources and Service Administration shows 60% of the medically underserved areas in the United States are rural. Can you explain the origins of Access TeleCare and how the company continues to serve rural communities?
Sure. So our organization is really the merger of 5 organizations that came together over the last several years. Two organizations, SOC Telemed, also known as Specialist on Call, as well as NeuroCall, that were focused on care of patients with neurologic issues. JSA Physicians and Forefront Telecare, which were focused on behavioral health. And then an organization I founded, Access Physicians, which was multi-specialty, focused on care of a broad swath of medical issues for patients in underserved areas. I think while the 5 organizations came from different roots in terms of the specialties that they practice, really the commonality amongst all of them was building programs to improve the access to specialty care for those in need. And by kind of just a distribution of patients across the United States, really since our founding, most of the organizations, if not all of them, have had an overrepresentation of patients in rural areas. And so while maybe 20% of US citizens are rural, and by definition, many of those are underserved, all of the organizations have had a majority of their practices caring for patients in rural communities. But almost every single one of the programs in which we practice is in an underserved area. So it's really been core to our mission to deliver specialty care to those in need who can't receive care that's timely, and really that's built around timeliness to improve outcomes. So we know that when we get to patients in specific windows of opportunity, that's our chance to change trajectory in their care, especially when they're hospitalized. And telemedicine is a great tool to enable that.
Great, thank you. Our next question is, many communities lack access to quality care in their communities. Can you explain some of the possible challenges in those communities?
There are so many. I had an interesting kind of path in my career. I started, and I'll kind of get to the answer here eventually, but I think it's relevant here in that so many of us, in terms of those who practice medicine, trained in large urban areas, and the concepts of patient care are really rooted in kind of what you learned and how you practiced and the resources you had available. Shortly after training, I went to be a chief medical officer of a 96-bed rural facility. I was about an hour and a half outside of a large urban center, and it was completely struck by just driving 70, 80 miles away, the difference in that community. It still had impassioned hospital leadership. It had impassioned and dedicated staff within the hospital, and it had a core group of medical staff. But what it lacked was kind of the full robust support that one would expect in large care centers, and it also had a challenging population that they themselves didn't have the resources necessarily to pay or cover or access all the care that they needed. And so when we kind of put that all together, the distance itself is a big challenge for communities that in terms of access, just getting to specialty care. And the distance also is a limiter in building out a robust medical staff. There's less opportunities for those medical staff to build practices, and a lower patient volume. And so oftentimes it's harder to recruit and to retain. And so oftentimes these communities, if they do have specialty providers, may only have one. That puts a lot of burden on a singular provider. And so, so not only are there geographic issues for just going to access specialty care, where patients have to take time off work or their family members and just drive, or other modes of travel, but then there's the recruitment and staffing is a challenge in itself. And then when we look at just insurance products that are available, the economies of the smaller communities may have less robust benefits packages. And so that also feeds into the resourcing or in the financials of the hospitals they serve. And so I think all of that kind of speaks to unique things that we see in communities that could be smaller or communities that are having challenges with access. I saw it firsthand as a CMO, and it's really what transitioned my career into telemedicine, where I saw firsthand its ability to again help. It's not the end all be all. It's not the singular solution, but it's absolutely a tool that can be used to help address the shortages related to specialty providers, and help hospitals care for a broader spectrum of patients, a more complex patient population, and keep more care local.
Next question. Because of the lack of access to care, what are some of the health outcomes?
Well, I think a lot of it deals with the specifics of their population. Oftentimes we see populations in more challenged areas are oftentimes older. They have higher degrees of morbidity than their urban counterparts. I think the simple publication of a zip code oftentimes can dictate so much in terms of patient outcomes. So I think that data is very well defined. Also, that oftentimes in underserved areas there are higher rates of smoking, obesity, and other chronic health conditions, which then play into. So it's the lifestyle choices and the behaviors that take place oftentimes that can lead to chronic disease and increased risk. And in many of those communities, there's also challenges with poverty and underemployment or unemployment, which limits the resources that the communities have to care for their populations. And all of this kind of feeds into a lack of access. And oftentimes it's more expensive or it's more challenging to stand up clinics, to resource hospitals in those areas. So I think those are many, but not all of the contributors towards disparities in health outcomes.
Great. Next question. Can you describe some of the benefits of telemedicine program to the rural community?
I think it starts with the ability to care for helping hospitals care for what walks in the door. And as we think about hospitals and the clinics oftentimes that surround the hospitals, they do what they can with what they have. And so many times the standard of care has been in underserved areas to leverage the emergency department to stabilize, to assess patients, to stabilize emergencies, admit what you can and care for what you can locally, but then really transfer out a good deal of patients to a larger tertiary care, quaternary care centered to manage more complex patients. And oftentimes, those patients that transfer out are transferring out not because there's a lack of staffing in a hospital in terms of the nursing staff and other support staff. It's not necessarily due to a lack of facilities. They don't have the beds, or they don't have the technology, or they don't have the diagnostic equipment or the lab equipment or pharmacy. They oftentimes have all that. And oftentimes they have an admitting or attending physician who can collaborate with the emergency department. They can make the right diagnosis, but the standard of care has really been that a specialist needs to weigh in and help co-manage that. And I think like one that's probably pretty classic is a patient that comes in with cardiac issues or chest pain, or a patient that is admitted with neurologic issues. Oftentimes, the admitting physicians just feel very uncomfortable managing those without a specialist oversight, or those who have very sick pulmonary disease or hypoxia would oftentimes want a critical care physician available just in case. And I think it's this, just in case kind of mentality, which is absolutely in the best interest of patient care and patient safety, that really leads to a lot of transfers. We always want to be concerned about what's the worst case scenario for patients, and we need to be prepared to handle the worst case scenario when a patient comes into the hospital, and that oftentimes is what drives transfers. And so, as we think about benefits, probably the number one benefit is to provide backup support and really a safety net for those patients that come into the hospital that's specialty driven. And so if they're coming in with cardiac issues, to have a cardiologist available to support the attending physician. If they're coming in with a complex infectious disease process, having an infectious disease doctor there to help manage the antibiotics, the duration, help in the selection of the antibiotics, and ultimately what their outpatient therapy is going to be. A mother that comes in with a known complex pregnancy, MFM support, so that that patient can stay and deliver their baby. And so I think the first is really providing backup and support from a specialty standpoint to assure that timely specialty care can take place to support what's going on. And what that does is it sets the stage and really lays the foundation for more patients to stay locally. And so that reduces transfers and helps hospitals drive admissions. And oftentimes those are the patients that are the sicker or more complex. And so just by nature of keeping the more sick, more complex patients, that imparts improvements in CMI, handling a more complex patient base within the hospital. It also reduces the need to use helicopters, to use ambulance to transfer patients out. So from a patient standpoint, that reduces expense. But we also know that patients that transfer have higher mortality. So their outcomes actually deteriorate when they transfer. Oftentimes we're transferring very sick patients. That time between facilities, there is risk there. And so we know that it improves patient outcomes as well. So I think those are kind of the big areas is first just that backup and support to improve capabilities, to be there to help reduce transfers and drive admissions for patients with more complex medical issues. That helps support and drive CMI, and then kind of just the reduction of overall utilization of transfer ambulances and helicopters that reduce expense. And I think all of that also, that probably the last thing is length of stay, is something that we try to see if we can tackle as much as possible in various specialties to help make decisions quicker and get patients out of the hospital as soon as it's appropriate.
And Dr. Gallagher, can you describe some of the financial benefits of telemedicine program to the hospital?
I think the largest have to do with the first and foremost staffing. So being able to provide staffing in kind of what you need. So sometimes hospitals don't necessarily need just one FTE. They need more or they need less. But really, when you're recruiting in person, you're recruiting in whole numbers, not in partial numbers. And so we're able to work with hospitals that may have one critical care doctor or one neurologist, and be there to work with them to provide 24/7 support, so that their in-person provider can can take a break, have their nights, have their weekends off, take a vacation from time to time. Or in hospitals where one isn't enough, that they need one plus every day, 24/7. And so we can augment. We've also worked with hospitals where telemedicine is the only solution because they're unable to recruit. And so they're oftentimes leaning on locums to provide support. And so we've seen first just the kind of reduction of expense around staffing, being able to have providers available 24/7 when the clinical needs warrant it is, I think, number one. I think number two is kind of on the comments I spoke on earlier, is just helping hospitals keep more patients that they're able to manage. And we're in our third year of a 30 hospital rollout with a system that covers kind of the Midwest and Central United States, where they rolled out tele-neurohospitalists in about half of their hospital. So in all 30 of their hospitals, they have a acute stroke and emergent neurology program. And in about half of those, they added a neurohospitalist program. All of this through telemedicine. And we implemented this with this system in 2021. We were fully live in 2022. And now here we are in 2023. And so we've been able to actually look at 5 years of data. So data preceding, data since rollout, and data 3 years after rollout. And what's been really interesting is, and we've actually had 2 hospitals that actually ended up stopping the program, is in the hospitals where we added a neurohospitalist, we saw an 60 to 80% reduction in transfers. And for that was really interesting for us because all of these hospitals had neurologists in the, through telemedicine in the ER, working to help support the emergency department in the decision-making process around what do we do, how do we manage this stroke, this status epilepticus, et cetera. But only in those where they had a neurohospitalist did they actually retain the patient to a large degree. And I think it really speaks to the earlier comments I made around supporting the hospital, being there to manage the patient when they're in the hospital. And so in those patients, when you look at their payer data, you can see significant increases in admissions because of the reduction in transfers. And with those admissions comes the additional revenue associated with those admissions. So I think, there's a decrease in cost when you look at being able to provide providers without the use of locums or augment in-person providers to prevent burnout. You can look at also, we now have great data around driving admissions to support revenue. With that, spoke earlier about shifting CMI because you're caring for a more complex patient base. And so I think those are 2 really, really important areas of telemedicine around cost and revenue that we've been able to observe in the hospitals in which we work.
Thank you. When it comes to behavioral health, specifically in the ED, what impact have you seen telemedicine make to those hospitals that have implemented that service?
Probably the number one impact is around dwell times. Often those patients which come to the emergency department with behavioral health crises, they can be very challenging patients. Oftentimes can be very distraught. There can be risk to themselves or risk to others. And so they oftentimes consume a lot of staff time in the emergency department. So they consume just general hospital resources. There's the bed and the room, but there's also staff who need to make sure that the patient is safe. Again, not a risk to themselves or others. And so without behavioral health resource there to assist the emergency department in assessing the patient, is this patient safe? Are they safe to go home? Are they safe to go home with follow-up? Do they need an inpatient admission? All of those decisions take time, and it takes an assessment. And oftentimes what we see is that the ability to get a telemedicine provider in there measured in minutes, not in days, can help accelerate that decision-making process, accelerate the disposition plans for that patient, and significantly reduce dwell times. And so that helps the emergency departments reallocate their resources. Obviously, ERs are very busy places. in terms of their staff and their beds. And the quicker we can help an ER, help an emergency room physician move a patient, help disposition a patient safely to what is the right next step for them, whether that is to go home, whether that is an outpatient program, whether that is move to an inpatient program, making that decision quickly. But also while we're waiting, helping to manage that patient so that it becomes a responsibility of our team to help co-manage that patient. So it, again, alleviates some of the pressure and strain on the emergency department. So dwell times and then just more hands to help with the work.
On that same topic of behavioral health, it seems that there are provider shortages nationwide, but specifically in Iowa. Can you describe how Access TeleCare has helped manage the influx of behavioral health needs in the state?
So I think, you know, we've seen definitely a shortage of providers, shortage of psychiatrists and mental health providers that are able to provide the care that's needed. And I think we are, without a doubt, and we probably everyone reads about this, if not once a week, at least several times a month, about just the challenges that are facing the healthcare system in terms of behavioral health crises and the need for treatment. And so, in addition to emergency department programs that we talked about earlier, we have consult liaison programs. So for patients that do get admitted to a classic acute care hospital, is having that consult liaison service to help co-manage patients that are admitted to a medical service as we stabilize a medical issue and maybe move them to an inpatient behavioral health unit, or just help co-manage through that hospitalization. So I think that's a big part of what we do in addition to the emergency department programs. Specifically, we've launched, I think, which is probably the most ambitious and largest hospital-based telemedicine program I've ever encountered. And we have yet to find one larger. And this was in Iowa, launched about 8 months ago, a freestanding behavioral health hospital that is over 80 beds, was running an average daily census in the 20s, and now staffed fully by telemedicine physicians and telemedicine nurse practitioners, has helped care for all of those patients every day, and now seen census grow into the 50s and into the 60s. So for us, that is an incredible achievement, one we're really proud of. Oftentimes when you think about virtual care programs, we're thinking about programs that are managing 5 or 10 patients in a facility, but then to grow to 5 or 6x of that and do it all through telemedicine, to help a hospital build census that had multiple units within it closed, because it just didn't have the provider base in order to care for the patients. I think it's a huge achievement in the field of telemedicine, one we're really proud of. And that hospital actually just went through Joint Commission accreditation and did it with a fully virtual medical staff, which was we were a core piece of that. And so I think that's been a great experience. Obviously, when you take on ambitious projects, you learn a lot. And so it's helped us really set the stage for how to work with hospitals of that size in the future. Behavioral health units, which are oftentimes smaller, 20, 12, 24 beds, is something that's been core to what we've done for many, many years, and have done that in the state. But growing to do a full freestanding hospital, fully virtual, was something that we think really helped push the ball forward in terms of the capabilities of what one can do with telemedicine. So we're glad to add that to the emergency departments, the consult liaison programs we've managed in Iowa, the behavioral health units, as well as now freestanding behavioral health hospitals.
Great. Let's switch over to the clinical side. We've got about 6 minutes here left, so 2 more questions. Describe 1 or 2 patient stories from your time with Access TeleCare of caring for critically ill patients all through telemedicine.
So I think I've referenced earlier my time as a CMO of a 96-bed facility. What I didn't share with everyone was that our very first telemedicine program that I was ever part of, our group was ever part of, was actually in that hospital. We unknowingly built Texas's first virtual ICU back in 2013. And 10-bed ICU was running an average daily census of 2. Number one reason that a patient was transferred out of the hospital was for pulmonary and critical care, and it simply just didn't have a critical care physician. So we were able to, I think we faced the challenges that so many face. We were unable to get one of our colleagues to even interview at the hospital for a year. So we attempted to launch a telemedicine program, and in the third night we had that program live. We had our first save, and that for us back at 10 years ago was, I think, really a defining and really career changing moment. Was to a patient that ordinarily would have been stabilized in the emergency department, who was with acute pancreatitis and septic and on the verge of respiratory failure due to acidosis. We admitted to the ICU. We were able to volume resuscitate that patient, stabilize their acid base issues, begin antibiotics, and support their acidosis and respiratory issues right there in the ICU. And the patient moved from the ED to the ICU and got care immediately. And being able to do that all virtually was really I think an impressive moment for all of us. I think the thing that really made it a special moment was we had known the medical staff, the attending physicians there for years. And this was, again, a rural hospital. So the physician on call did exactly what they had done for their entire careers. They took home call. And when a patient was sick, they got out of bed, got in their truck, they drove the 30 minutes from the ranch to the hospital, walked in, and that whole process takes about an hour. And that family practice physician walked in the ICU and stood there and watched the telemedicine provider, pulmonary critical care physician, manage that patient for an hour, and just stood there and watched, and then turned around and said, I can go home, and went home and went to bed and came back and told everyone the next day. And that's a moment that's really kind of as fresh today as it was 10 years ago. And that for me is an incredible illustration of what we can do when we put telemedicine programs into hospitals. It changes outcomes, provides timely care. It helps extend and supports the existing medical staff so that they can do their thing in person, but they also know that they've got the safety net and support of colleagues who can allow them to have some downtime.
Yeah. Great. What a powerful story. Thank you. Last question here. What impact have you seen a telemedicine program have on hospital staff?
Well, I think for us, some of the most rewarding is to see a hospital staff view the telemedicine staff as part of the medical staff. They view them as peers. And in some cases, we're working with hospitals where they just can't recruit. They maybe lost a few people who have either moved away or people who have retired. And we just launched a recent hospital in the Midwest where the community physicians were just unable to continue to cover the inpatient service, the hospital service, in addition to their outpatient clinics. And so we began to help support at night. And within a handful of months, the medical staff said, you guys have this, take it 24/7. We'll stay in our clinics. And so we launched that program with about 5 weeks notice. And then in just a handful of months, turned it to a 24/7 program. So that was one that's very recent, where the hospitalist actually shifted and requested us. And so it was really great to see us seen as equals. And then I think, we hope every program lasts forever, but we all know that they don't. And sometimes we have programs that get terminated. And we had an infectious disease program recently terminated to reduce expense for the hospital. And within a couple of weeks, the medical staff had several meetings with the CEO, and the hospital has had our infectious disease program reinstated. And so it was actually the first time in my career I've seen that, where medical staff who, not part of our group, they're boots on the ground, in-person traditional hospitalists, Another group actually felt that the program was so impactful to the work that they did and so important for patient care that they had a contract reinstated. So for us, I think those are two stories that demonstrate the what can be done, the relationships that can be built, and the respect that we can develop for each other as peers.
Great. Thank you, Dr. Gallagher. That was our last question. If anybody listening now has any questions, we're at 3:30, but if you got a quick question, I'm sure we could answer it real quick.
Absolutely. Thank you so much, Dr. Gallagher and Jim. But yes, we'll pause for one more minute. If you can type in your questions using the Q&A tool, or you can raise your hand and we can unmute your microphone if you want to verbally ask a question. So we'll pause 30 more seconds, see if we got any audience questions. And just a reminder, I'll post this recording on the ServiceShare website on the education page, where we have on-demand educational offerings like this one. Okay, with that, I'll turn it back to you, Jim, for any closing comments. And again, thank you all for your attendance today. And we look forward to seeing you next time.
Yeah, thank you, Joa. Thank you, everybody, for jumping on. If you have any questions about telemed, shoot Reagan or I an email, or Jake. You all know Jake from his past role, but these folks have been partners of ours for many years and do great things here in Iowa. So any questions, please reach out. We'd be happy to get you in touch with the right folks. Have a great Merry Christmas and a Happy New Year, and we'll talk to you all soon, I hope.
Great. Thanks, everyone. We'll conclude the session at this time.